Hello, I'm Jim Essell. I'm the medical director of the Blood Cancer Center at Jewish Hospital in Cincinnati, and I'm also the chair for cellular therapy for SCRI. Today, we're going to talk about moving CAR T to the community. First of all, why is this important? Well, right now, only approximately 20% of patients eligible for actually getting CAR T are receiving it. And there's many reasons for this. One is geography. Right now, most of the treatments are done at major medical centers, and patients may not be able to travel that far. They need to have not only the patient go there for a month, that the caregiver has to take off work, which creates a problem with cost, with no one working. There's competition with bispecific antibodies. I think patients just simply aren't being referred. And there's also in the community a perception of toxicity from when CAR T first came out, and it was much more toxic therapy. Back at that time, we would wait until someone had significant CRS to treat. Now there's regimens where there's prophylaxis, with certainly treating before one gets to grade 3 or grade 4. So what's required to move this out into a community practice? First of all, there has to be a physician champion, someone who's going to lead the charge. They need to have a hospital partner, and that physician champion is going to have to work in their own group to make it creates more work to make sure their partner is willing to take the extra calls to deal with the sick patients. And then they have to coordinate with the hospital so that if the patient goes to the emergency department, they're trained, the ICU, neurology, nursing, pharmacy, so that everybody can work together to give this potentially life-saving therapy to patients that can become critically ill. There's two basic models with CAR T from a financial standpoint. One is to partner with the hospital. The hospital holds the contract. That gives the potential for 340B pricing for the hospital to cover some of these costs. One of the issues is many of the insurance companies for high ticket items like this have global contracts, something more difficult for a physician group to do. The other model is for the physician group to hold the contract. The lymphodepleting chemotherapy and infusions are done in the physician's office. The patients are only admitted if they have a complication. For this, there is a risk if reimbursement is not adequate at $500,000 a dose. A few patients are treated and the reimbursement is not obtained, can put the physician group literally out of business. To do this, there needs to be a large volume of patients to cover the cost of those who have complications and offset with that with the patients that do well. And both of these models are in practice right now. Other barriers, one is fact. For a transplant center, such as where I work, it was easy to add cellular therapy to it. For a physician group that has a physician champion and has buy-in and everybody wants to do it, it's still a hurdle to set up with fact. Pharma is now authorizing treatment centers without accreditation, but still insurance companies may require fact accreditation or send their patients to centers of excellence. Cost is certainly a barrier, as we talked about before. Need to make sure that there's a large enough volume. This shouldn't, and from a clinical standpoint, shouldn't be 1 or 2 cases a year, to make sure the expertise is there, but also to make sure from a financial standpoint that things work. And then call. As groups have gone from inpatient call and taking care of it, now oftentimes the patients are admitted through the emergency room to a hospitalist. If this is the model, I think you really need to have a oncology hospitalist or really training with your hospitalist to manage these patients with cytokine release syndrome and neurologic toxicity, something they may not be familiar with. And then also in the oncology group, you may have those physicians who focus on malignancies and are completely aware of how to manage cytokine release and neurotoxicity. But remember, they're not on call every night. The breast cancer doctor and sarcoma doctor have to be up to speed and also willing and excited to do this type of work. So can this be done? The outreach study, which actually took 79 patients that received Essell for relapsed refractory large cell lymphoma at community sites, 66% were FACT, 34% were non-FACT sites. And this included many sites that had no experience with CAR T whatsoever. So it was really their first stepping the toe into the water of CAR T. And was this safe and effective? Well, this was presented at ASH, and there's been other updates, and this will be published, we hope, in Blood Advances in the near future. But you can look for this under the outreach study, and I'll go right to the conclusions here. And you can see they were picked for outpatient or inpatient at physician discretion. So there may be a bias here that patients with bulkier disease were not quite as hardy were admitted, and those that were not were outpatients. But you can see CRS here, 37% compared to 44%. Management, as far as the amount of TOCI and corticosteroids in the two columns. But going on down to efficacy, overall response rate, 83% versus 72%. And really with CAR T, what's important is CR rate, because those are the patients that long-term are going to do well. 57% for outpatients, 40% for inpatients. Again, there may be some bias involved here. But overall, the conclusion of the study was acceptable safety profile in both inpatient and outpatients, regardless of if they were at a previous transplant site or not. 24% of the patients were never hospitalized. 31% of those hospitalized have been less than 4 days. And the data in this study, I think, clearly shows that administration at community sites in the outpatient setting is safe and effective. So it answers that question in my mind that yes, it can be done, just getting the logistics of how it can be done. Some things that we're working on and places around the country are working on to try and make this safer is wearable technology. For example, a wearable thermometer that monitors the patient. We want the patients checking their temperature and reporting to us if they have a fever, but you want the caregiver and patient up all night long checking temperatures. This sends a message to their smartphone, which can either go to the physician, or what we do is we send it to the caregiver, so we're not calling and trying to wake someone up and they don't answer the phone at night. Caregiver calls us and we can manage them appropriately in a quick time. Companies are working on vital signs via the smartphone. So kind of like if you're looking at setting up facial recognition on your smartphone, it will get your pulse, your blood pressure, your vital signs, soon oxygen saturation. You'll have your monitor already looking at temperature. That would automatically give that. And then we're working with a company called Canopy, looking at artificial intelligence software that will prioritize, first of all, a CAR T patient. So that goes to the top of the list of the triage nurses. So they're not getting a request for a Zofran refill, and this gets buried in there. And it guides the nurse on if they have a fever, for example, which is the hallmark of cytokine release syndrome, automatically get that patient in to be evaluated versus other symptoms. And I think ultimately, which will really be great, is if we can have that type of software merged with these vital signs so that coming back to the office on a regular interval will be their vital signs, how the patients are feeling. And if the patient doesn't send this, then we call them. So that's in the very near future will be coming to hopefully make this a whole lot easier. In conclusion, more indications are coming quickly. Autoimmune disease is not yet FDA approved. There's already a study in the New England Journal that shows great efficacy, and there's more autoimmune diseases than there are cancer. One of the questions, who should be administering CAR T in the future? Is this only going to be at academic medical centers? If that's the case, there'll be a tight funnel on the number of patients that can be treated. Will non-oncology diseases be treated by oncologists, such as autoimmune disease, multiple sclerosis, or will there be specialty training for these specialties? Another year of a rheumatology fellowship, for example, which is now pretty much an outpatient practice. Will they be divided like cardiologists with invasive cardiologists and non-invasive cardiologists? Same for rheumatology. Or will it go to the cellular therapy doctors? And then other things to try and make things safer, not only treating patients earlier with onset of symptoms. Zuma 24 is published, shows prophylactic dexamethasone does decrease the length and severity of cytokine release syndrome. There's other studies looking at prophylactic tocilizumab. And then I think another unanswered question is sequencing with bispecific T-cell engagers. Right now, the data and what we usually do is start with CAR T and then use the bispecifics as a salvage. Will the bispecifics be used, for example, for bridging? It's unclear right now. And my fear is that sites that do not get up to speed or say, well, this CAR T is too toxic, there's too many hurdles to get this going, will not refer their patients and just use bispecifics, where we don't have the long-term data that shows some of these patients can actually be cured. So with that, I'd like to stop and thank you for listening. It's been my pleasure to present how to move CAR T to the community.